Let us continue the second session for the therapeutic of bronchial asthma and COPD. In the first session, we discussed the prescriptions and the drugs that are used in the management of status asthmaticus and acute and chronic asthma in the children 0 to 4 years of age and 5 to 11 years of age. Let us continue to the management of bronchial asthma into the youth more than 12 years of age and in the adults. The treatment of intermittent asthma, or we can say acute asthma, is the same for all age group including adults. For the intermittent asthma and the acute asthma, we need only short acting beta agonist, maybe in the form of nebulizer, meter dose inhaler, as per the age group. As we discussed the treatment plan of asthma for the 0 to 4 year of age, there is no use of theophylline, but in the age group of 4 to 11 year, there is an inclusion of theophylline, which is having bronchodilator as well as anti-inflammatory properties in the management of bronchospasm. Let us see what is the difference between the management of bronchial asthma in more than children more than 12 years of age and adults. For the persistent asthma, the daily medications include step 2, which is preferred low dose inhalational corticosteroids, that is fluticasone or budesonide. Alternative, leukotriene receptor antagonist, that is montelukast or theophylline. Same as the previous age group 4 to 11. Step 3, medium dose inhalational corticosteroid or low dose inhalational corticosteroid with long acting beta agonist. And there is alternatives are available: low dose inhalational corticosteroid plus either leukotriene receptor antagonist, that is montelukast, either theophylline or xylitol. Xylitol inhibits the release of leukotrienes. Xylitol, take a note, xylitol is not a leukotriene receptor antagonist, but it inhibits the release of leukotrienes. So step 3 medications, there is addition of the xylitol. If the patient did not get benefit on the previous step 2 and 3 medications, patient can jump on the step 4 medications, and it includes medium dose inhalational corticosteroids plus long acting beta agonist, and alternatives are available if the patient is hypersensitive or contraindicated to this drug. Then patient can use medium dose inhalational corticosteroid plus either montelukast or theophylline or xylitol. If the patient did not get benefit on this step 4, he can jump on the step 5. It includes high dose inhalational corticosteroids plus long acting beta agonist. And here consider omalizumab for the patients who have allergies. Omalizumab is the monoclonal antibodies and generally recommended for the patient who has allergic asthma. If the patient did not get benefit on the step 5, he can jump to the step 6, high dose inhalational corticosteroids plus long acting beta agonist plus oral corticosteroid. So in the step 6, there is inhalational plus oral corticosteroids, and means there is important plus add or consider omalizumab for the patients who have allergies or allergic asthma. The difference of medications among the previous age group 0 to 4 and 4 to 11, there is addition of the theophylline, xylitol, and omalizumab. These three medications are not available in the protocol of 0 to 4-year children's for the management of asthma, persistent asthma. There is one note: consult with asthma specialist if step 4 care or higher is required, and it is recommended to consider consultation at step 3. And as we discussed before, step if step up if needed, and it's very important. First, check adherence, environmental control, and also comorbid conditions. And step down if possible and asthma is well controlled for at least 3 months. So if asthma is controlled for 3 months, the patient can step down from 6 up to the 2 to minimize the adverse effect of drugs. So these are the main difference between the medications which are used for the management of persistent asthma in 3 age groups: 0 to 4 year of age, 4 to 11 year of age, and more than 12 an adults group. Write the preferred drug, and drug should be avoided in following many cases of bronchial asthma. there is a mini case. You have to write the preferred drug and drug should be avoided. Let us see the first case. A 6-month-old boy with intermittent bronchial asthma. Now here you need to consider the age group, 6 months, with intermittent bronchial asthma. As we discuss, the preferred drug is short-acting beta agonist, albuterol, or we can say salbutamol is the preferred, and we can say the choice of drug in the management of intermittent bronchial asthma in 0 to 4 year of age children. Avoided drug, avoid the salmeterol, which is the long acting beta agonist. The long acting beta agonist generally not preferred in the treatment of intermittent bronchial asthma. Next case. A 7 years old girl with persistent bronchial asthma. Consider the age group 7 year and persistent. As we discussed in the step 2, the preferred drug is low dose inhalational corticosteroids, budesonide, or alternative is montelukast, which is leukotriene receptor antagonist. Avoid the drug omalizumab, which is monoclonal antibody. You can also write salmeterol as the avoided drug, or we can say long-acting beta agonist. Next case, a 29-year-old pregnant woman with intermittent bronchial asthma. Now the asthma is intermittent, and for all intermittent bronchial asthma, the preferred drug is short-acting beta agonist, that is albuterol inhalation is the first choice, and avoided drug is salmeterol because it's an pregnancy category C as per the FDA categories of the drug. Next case, a 2-year-old boy with persistent bronchial asthma, not controlled by low dose inhalational corticosteroid and the montelukast. As per the treatment protocol, if this is the step 2 drug for the persistent bronchial asthma, if it's not controlled by the low dose inhalational corticosteroid and montelukast, as per our protocol, the preferred drug is medium dose inhalational corticosteroids, and drug should be avoided is salmeterol and omalizumab, that is the monoclonal antibodies and the long acting beta agonist.